Clinical methods in obstetrics and gynecology. Okay, so for this particular lecture, we're going to discuss history taking, physical examination, the various investigations, and also we deal with case presentations. Okay, so always remember the physician-patient encounter. So the patient seeks medical help from the physician, and the physician also seeks to diagnose and manage the patient. So making a diagnosis is part of the process, and with the correct diagnosis, a proper management and treatment plan can be made. The clinical methods involve eliciting and applying the symptoms and signs of diseases, and making of clinical diagnosis. So that's basically what clinical methods is. So for the history taking, it is the art and practice of communication to obtain information of the illness as perceived by the patient. The history guards itself in details, and it directs the extent of physical examination and investigation. So communication is a communication process. You greet, you self-introduce, you introduce yourself at the beginning, and you ensure privacy, confidentiality, and concerns of sensitive issues too. So there should be respect, interest, and the right attitude, like putting on a smile, and not being judgmental, and it should be tailored to suit the situation, such as in OPD, in emergency cases, also from relatives too. There's a need for chaperone. Mm, that's when you're doing some examinations too. You have to be aware of the types of people you meet over there too. Some are shy, talkative, and others are also depressed already. Okay. So with the history, demography, you look at the name, the age, the address, the occupation, and the marital status. And then the present complaint is basically the statement by the patient of the general nature and the duration of the main complaint. The reason for seeking care is basically the presenting complaint, and also the problem as perceived by the patient, the symptoms of the disease. Sometimes you have to be aware the real reasons may be hidden. So the history of presenting complaints, the chronology of the symptoms, including the manner of development, the actions taken. So for key symptoms, you provide details through direct and certain questions like for pain, you have to know the sites, the nature, relieving aggravating factors too. For bleeding, the amount, provocation, and effect. Vaginal discharge, the color, the amount is associated with itching, the odor, relation to menses too. And also review the other systems through direct questions, anxiety, cardiorespiratory symptoms, the genitourinary, psychomotor, and central nervous system too. Other areas that you look out for is the gynecologic history. So here you ask about menarche, menstrual cycle, the duration of bleeding, the length associated with pain or not, blood loss, clots, mid-cycle pain, also previous pelvic infections, and also sexual, if there's coitus, the coitus, if there is dyspareunia, postcoital bleeding, you ask all these things too. And contraceptive practices too. So others, you ask about clinical breast examination and screening for the cervix. The past obstetric history, you list all the previous pregnancies, the outcomes, deliveries, the abortions, ectopic stillbirths, they should all be indicated over there too. And other areas, you look for the obstetric patients, after the demographics, you add the LMP, the last menstrual period, should be noted so that the estimated gestational age can be calculated. Also, if an early ultrasound that's between 11 to 14 weeks had been done, then that is used to calculate the estimated gestational age and the expected date of delivery. The gravidity and the priority should also be noted. For example, is it gravida 4 para 2 alive plus 1 is the spontaneous abortion, as the patient had 4 pregnancies with 2 deliveries and 1 miscarriage. So note gravidity, um Note that the gravidity is basically the total number of pregnancies, regardless of the outcome, and priority is the number of live births or stillbirths at any gestation after 28 weeks. Okay. Other areas to look out for the obstetric patient, the current or index pregnancy comes in. Has the pregnancy been eventful the last menstrual period? Has the pregnancy been dated? What's the expected date of delivery? Has ANC been started? Is the patient on any hemantinics? Has tetanus injection been given? And has any of the routine pregnancy labs been done? Are there any problems with them? Also, for past medical and surgical history too, any previous serious illness, you list them, any surgeries, admissions, hemotransfusions, and also medications, long-term drug use, current drugs and allergies to you, note all of them. The family history is a family history of hypertension, breast and ovarian cancer, multiple pregnancies, and also communicable diseases too. You note all of them down. Finally, come to the social history, the marital status, occupation, income, housing, the religion and denomination. Okay, so alcohol, smoking, drugs, you list all of them down. So after everything, you come to the summary. So summary of everything, you note the age, the priority, gravidity priority, key symptoms and other issues as obtained from the history, and then the history should then guide you as to what physical examination should be emphasized. So their parts out may need complete examination, other parts to just a brief examination. Okay, so that's basically with the history taken. So with the physical examination, it is basically the art and practice of eliciting physical signs of illness from the patient. It begins with the history taken, so that will just show you where to really do an complete examination or brief examination. So the history taken continues into the examination. So you have to be gentle, you have explanation, you seek verbal consent, avoid undue exposure. So for the physical examination, the tools or what we normally use is permission, doing inspection, palpation, percussion, or auscultation. Okay, some of these things have been used, others aren't done. And you need a chaperone, and basically the physical examination consists of general examination and regional or systemic examination. So the general examination involves the exposed parts of the body, so the position, whether in supine, in an anatomic position, you play, and if the patient is on a bed, you note that too. So the position of the patient, it could be in supine or tetomy position or wherever position that you want to place the patient. They give a quick assessment of the patient, the general state of health, build hydration, distress in pain, life-threatening conditions. You just state all of them, and the vitals, the temperature, pulse, respiratory rate, the blood pressure, the head, whether there is pallor, jaundice, neck swelling, lymph nodes, cervical, mandibular, clavicular lymph nodes, extremities, whether there is edema, the weight, height measurement too. Okay, so you determine whether life-saving procedures are required before proceeding, so you don't waste time with any other examinations, or the patient is probably in shock or something else. So you obtain the body mass index with a normal formula we know, that's kilogram over meter square, and you categorize a patient as either underweight, that's below 20 grams kilograms per meter square, or normal, that's from 20 to 24, overweight 25 to 29, and obese above 30 kilograms per meter square. So with the original examination, head and neck, so the chest, original examination, basically the head and neck, the chest, you look out for the breast, heart and lungs, the abdomen and the pelvis. So with the breast examination, you inspect breast examination. On inspection, you look at the asymmetry, whether the breast is symmetrical, asymmetry, the vessels, skin changes, ulcerations, nipples, cutaneous attachments, retractions. Also for palpation, the four quadrants of the breast, the areola, axillary tail, supraclavicular nodes, infraclavicular nodes, the nipple discharge, and check axillary for node enlargement. So for the chest cardiorespiratory exam inspection, look out for dilated vessels, apex beats, chest wall symmetry and deformity. Palpation, the apex beat trails, parasternal hips trails, tactile fermitous, chest wall expansion, percussion, either anteriorly and posteriorly too. And the quotation heart sounds, members entry, breath sounds, added sounds, vocal resonance. Gynecological examination, as in abdominal exam, first let the patient see the bladder. It should be adequate exposure, inspection, the size, shape, contour, scars, skin changes, palpation, basically pointing sign of tenderness, superficial palpation for tenderness and masses, and deep palpation for masses. Basically, the liver, spleen, kidneys, pelvic mass, for example, the uterus. Percussion, as when indicated from the history, you do a flow through and shifting dullness. Auscultation, bowel sounds when indicated. So, abdominal exam in obstetric cases, inspection inspect for the shape, size, contours, scars, skin changes, fetal movement, and palpation, pointing signs of tenderness, superficial palpation for tenderness and masses, and deep palpation for masses like enlarged liver, spleen, kidneys, in pregnant uterus, gravid uterus. Auscultation for obstetric cases, fetoscopy, listen to the fetal heart rate. Normally, after 24 weeks, you can hear with a fetoscope, fetal stethoscope, the sonicade is clear after 10 weeks. So the examination of the gravid uterus or pregnant uterus, and there are four steps that we use. Estimation of the gestation period using a simple fundal height SFH, and for fundal palpation it determines the contents of the upper pool, uterine pool, the presentation in the line, the lateral palpation as it locates the back of the fetus for position, and also for the line and pelvic palpation for presentation, position, descent, and engagement. So, basically, pelvic examination, you need a chaperone, and the patient has to empty her bladder unless for stress incontinence. The position it should be in dorsal position with flexed hips, left lateral, or it could even be in totem position. Okay, so examination, you have to explain the procedure, seek verbal consent. Next, extreme decency required, you wear your gloves. So inspection, the vulva and the troches for degree of development of or atrophy of the labia, head distribution, the size and the clitoris, the discharge, warts, scars, swellings, ulcers. It asks the patient to cover bed down if stress incontinence or retrovaginal prolapse is suspected. And for speculum examination, as part of the inspection with either a couscous bivalve or some speculum to view the cervix or vaginal wall. So palpation, you observe the patient throughout to exclude tenderness. Palpate the Bartholin's glands with the thumb and index finger, and insert the lubricated middle gloved finger of the right hand into the vagina and use it to depress the faucet to allow for some space so that the index finger can be slipped into the vagina. You work with the two fingers gently towards the cervix and you place the left hand on the suprapubic region for bimanual examination, and you milk the urethra for discharge. So for the cervix, you look out for consistency, the mobility, the position, tenderness, the os, whether it's open or closed. And the uterus, you look out for the size, the shape, mobility, consistency, and the anexa. And for the vagina, the phonetics, the walls, the rugi, and you milk the urethra for discharges. For rectum or retrovaginal, you examine as indicated. And after the examination, you thank the patient for the cooperation, politely ask the patient to dress up, and then you put together the history and examination findings for a diagnosis or differential diagnosis, and you select your investigations. Okay, so for the investigations, we have um, the routine and the special. The investigation is basically seek to confirm or rule out differential diagnosis, and you provide a baseline to allow monitoring of disease or treatment. It comes from the main domain of laboratory imaging and endoscopy. So it's chosen based on the history and physical exam, as well as consideration of costs, availability, and suitability. So the two main groups are whether it's routine or special. Routine is done in all patients and nearly all cases, provides screening and baseline for further tests. Blood, FBC, full blood counts, clean blood group and resource, blood film for malaria, urine, urinalysis for protein, sugar, and microscopies to microscopy. And for special investigations, it's chosen to confirm, exclude, or assess a condition like hematology, clotting profile, you suspect coagulability, um, or coagulopathies, and platelet count, as in eclampsia, to detect DIC, disseminated intravascular coagulation, and bacteriology, culture and sensitivity tests for urine, blood, swabs, endocervical, high vaginal, urethral swabs for staining and microscopy. Okay, biochemistry, FBS, RBS, GTT, and organ function, renal function tests, liver function test, and thyroid function test. Endocrinology and infertility, you can do hormonal assays, estrogen, progesterone, luteinizing hormone, follicle stimulating hormone, prolactin, check the androgens and beta HCG. Some analysis too could be done, and hysterosalpingography, hysterocontrast sonography, and endometrial biopsy. As in other special cases to the imaging, ultrasound, x-rays, mammogram, um, intravenous urography, computed tomography, as an evaluation of the extent of the disease in a patient with cervical carcinoma, screening lymph nodes for metastasis, and also magnetic resonance imaging. In other special cases, to do endoscopy, colposcopy, diagnosing cervical, vaginal, and vulval lesions, hysteroscopy, as abnormal uterine bleeding, Asherman syndrome, hemorrhagia, and also laparoscopy, ectopic pregnancy, pelvic pain, cystoscopy in bladder abnormalities, and proctoscopy and sigmoidoscopy in rectal disorders. For other special cases too, you can do fetal investigations like fetal kick count, cardiotocography, biophysical profile, chorionic villus sampling, amniocentesis, and fetal scalp blood sample. Other special investigations too include serology, examination under anesthesia, pap smear, cone biopsy, diagnostic dilatation and curettage, also cold dose synthesis. Okay, so basically the last aspect of this case presentation is just a systematic way of communicating the history, examination, diagnosis, investigations, and plan of management to colleagues. And it's a skill required through meticulous training and practice, a product of sound theory and clinical skills. So basically there's something real about the um, clinical methods in obstetrics and gynecology.